Consider this clinical presentation. A 31-year-old female presents with a 2-month history of postcoital bleeding. Her last pap smear, taken 2 years prior, was completely normal. Deciding the precise next steps in her management requires us to map this single symptom, non-menstrual bleeding, directly to the underlying tissue architecture. The cervix functions as the cylindrical lower extremity of the uterus. Physically, it is divided into 2 distinct cellular microenvironments. This diagram maps the ectocervix, whose outer surface is thick, non-keratinized stratified squamous epithelium, a robust protective layer. Moving inward to the endocervical canal, the lining abruptly shifts to a fragile, simple columnar epithelium. The border where they meet is the squamo-columnar junction. This junction is not static. Its continuous physiological shifting throughout a patient's life creates a structural vulnerability that dictates nearly all cervical pathology. This image presents our first differential diagnosis for postcoital bleeding, cervical ectropion. You can clearly see a red, circular area surrounding the external os. Ectropion occurs when the endocervical columnar epithelium extends outward onto the vaginal portion of the cervix. This outward shift is driven by hormonal changes, primarily associated with the 3 Ps: puberty, the contraceptive pill, and pregnancy. Because the exposed columnar layer is a fragile single-cell structure, minor physical trauma, such as coitus, easily triggers bleeding. Despite its raw visual appearance, ectropion is a normal physiological finding. It should never be mislabeled as an erosion or an ulcer. This brings us to a second structural differential: cervical polyps. These are benign tumors arising directly from the endocervical epithelium. Polyps are often discovered incidentally in asymptomatic patients. However, their highly exposed vascularity frequently leads to both intermenstrual and postcoital bleeding. Let's examine a third, non-bleeding structural anomaly. This specimen shows Nabothean follicles, distinct mucus-filled cysts visible on the ectocervix. These form through a simple mechanical process where columnar glands become sealed over within the transformation zone. They hold no pathological significance. Structural abnormalities frequently cause bleeding simply by exposing fragile tissues to physical contact. Yet a rigorous diagnostic protocol must actively rule out microscopic cellular pathogens before confirming a benign source. This requires evaluating sexually transmitted suppurative cervicitis as a primary infectious cause for the patient's bleeding. The first major pathogen is Neisseria gonorrhea, a gram-negative coccobacillus that specifically targets and invades the columnar and transitional epithelial cells. The second is Chlamydia trachomatis. As an obligate intracellular parasite, it targets those exact same endocervical columnar cells for infiltration. The clinical presentation diverges here. While ectropion may produce a clear discharge, active glandular infection generates profuse, mucopurulent vaginal discharge alongside the bleeding. To accurately isolate these pathogens, nucleic acid amplification tests are required. They provide the high sensitivity and specificity necessary for definitive molecular identification. Once identified, the pharmacological response is strict: ceftriaxone combined with azithromycin for gonorrhea and doxycycline to clear chlamydia. Infectious cervicitis actively degrades cellular integrity. We must achieve precise molecular identification and clear any infection before we can safely rule out premalignant processes. Returning to this histological illustration, the squamo-columnar junction retreats toward the external os in adults. This retreat is metaplasia, the transformation of vulnerable columnar epithelium into robust squamous epithelium. This geographic area of continuous cellular turnover is the transformation zone. This zone of rapid cellular immaturity creates a specific pathological threat. It is highly susceptible to persistent infection by high-risk human papillomavirus. While low-risk HPV strains cause benign warts, there are 13 high-risk types, specifically types 16, 18, 31, 33, and 45, that possess oncogenic capabilities. Upon infecting the transformation zone, high-risk HPV DNA integrates directly into the basal epithelial cells. This disables normal apoptotic pathways, leading to cellular immortalization. Histologically, this disordered immaturity completely disrupts the epithelium. orderly cell layers are replaced by immature cells with enlarged, hyperchromatic nuclei, a state defined as cervical intraepithelial neoplasia, or CIN. In most patients, HPV infections are transient. But specific risk factors, namely smoking and long-term immunosuppression, prevent viral clearance, guaranteeing the persistent infection required for oncogenesis. The physiological necessity of metaplasia creates the exact cellular engine that high-risk HPV hijacks to initiate lower genital tract malignancy. We can now return to the 31-year-old patient presenting with 2 months of postcoital bleeding. She sits at the center of a strict diagnostic trap. From benign ectropion to structural polyps or infectious cervicitis and precancerous CIN all perfectly overlap to cause this exact non-menstrual bleeding pattern. Because of this symptom overlap, visual inspection alone is completely insufficient for a definitive diagnosis. The first required clinical action is to obtain endocervical and lower genital tract swabs. We must definitively rule out chlamydia and other sexually transmitted pathogens. Concurrently, we must secure updated cervical cytology. This is mandatory to formally exclude the presence of premalignant CIN and evaluate for any malignant staging. Effective gynecological care requires treating a bleeding cervix not as an immediate visual diagnosis, but as an anatomical map. It demands the systematic elimination of structural, infectious, and molecular threats.